Good morning, everybody. So my name is Sarah Strauss. I'm a stroke neurologist. I work at in New Jersey, and I'm going to talk about the diagnostic pathways for ESUS, and mainly the clinical challenges associated with that. So I'm just going to start out with a case. This patient is a 57-year-old gentleman. He is a lifetime non-smoker. He does have diabetes. His A1C is 12, hypertension, hyperlipidemia. He uses occasional alcohol. So he presented to the ED. Upon waking up that morning, he noticed right-sided facial droop and some mild dysarthria. And he presented to the ED. His NIH-SS was 2, 1 for facial droop, 1 for dysarthria. As you can see, his vitals are stable, 148/87. His blood glucose was elevated. He was in normal sinus. He was unfortunately outside of the TPA window. He was loaded with aspirin, started on a statin, and he was admitted for further workup. So as you can see here, his diffusion MRI shows this acute stroke in the left frontal lobe, and also a very small punctate infarct in the left cerebellum. His flare didn't show any other prior strokes. He didn't have any significant other cerebrovascular disease-like changes. So CTA neck, I'll sort of scroll through here, was essentially unremarkable. He did not have any significant atherosclerosis, as you can see. Again, the CTA neck axial views obviously here. There's no significant atherosclerosis or stenosis that we could see here. And in the head, again, CTA of the head did not show any significant stenosis or atherosclerosis for that matter. And I'll scroll through here so you all can see. So essentially normal. And we'll sort of jump back to this patient later on. So traditionally, typically ischemic stroke, you have to figure out what the cause is. And typically, it's divided into categories based on what the etiology is. But a lot of patients are placed into this cryptogenic stroke bucket. Calling something a cryptogenic stroke can be kind of ambiguous, and it also depends on the extent of the workup you do, which is where ESUS comes in. So ESUS was a concept that really came about stressing that many patients that are considered to have a cryptogenic stroke are actually from some sort of embolic mechanism. And the definition or diagnostic criteria for ESUS implies that you do a basic completed workup. So again, the diagnostic criteria definition is a stroke that's not lacunar based on brain imaging. There's no significant ipsilateral stenosis based on imaging in the intracranial and extracranial vessels, and a basic cardiac workup, including EKG, transthoracic echo, and about 24 hours worth of telemetry monitoring has been done. But keep in mind, further workup like a transesophageal echo or prolonged heart monitoring, again, is not a part of this diagnostic criteria. So, that being said, although it's likely from an embolus, the origin is still unclear, and finding the exact source of this embolic stroke really depends on how far you go with the diagnostic workup and even interpretation of the diagnostic workup that you do. And keep in mind, other mechanisms are still possible. That being said, there's multiple potential etiologies here, and identifying the actual source is, the main diagnostic challenge here. So multiple potential sources are possible. So number one, non-stenotic atherosclerosis, whether intracranial, extracranial, in my opinion, is probably the number one thing to think about. The aortic arch, some people would think of the aortic arch as an organ in itself. So aortic arch atheromas have to be investigated. Any sort of systemic process, a hypercoagulable state, autoimmune phenomenon, and paradoxical embolism when it relates to right to left shunts, and other cardiac abnormalities such as subclinical AFib, or other subtle cardiac problems such as atrial cardiomyopathy or valvular disease, etc. So there's a lot of different things that can be going on here. Speaking of AFib, we know that AFib is a huge problem. It's unclear exactly how many ESUS patients will go on to have AFib, but we know that the longer you monitor for AFib, the more chance of finding it. So this is from, a lot of people might know this, the Crystal AFib trial. And they basically took cryptogenic ischemic stroke patients and they inserted insertable cardiac monitoring or loops. And as you can see, as time goes on the bottom axis here, this is months and this is rate of AFib detection, the amount of AFib just increases over time. At 30 months, I think it was 30% of AFib was found. And this is in patients with a cryptogenic stroke. And this is using a threshold of 30 seconds of AFib. This study, in my opinion, was even more crazier. So this is the REVEAL AFib study. And these are patients without a history of AFib, not even with a stroke, just risk factors for AFib, hypertension, etc. And they followed these patients over time after inserting a loop or cardiac monitor. And as you can see, over time, the rate of detecting AFib with a threshold of 6 minutes just increases over time. At 18 months after insertion, 30% of these patients were found to have AFib. The mean age in this particular group was 71. The mean CHA2DS2-VASc was 4. And again, the majority of these patients, there was about just under 400 patients they used, didn't even have a stroke or a TIA. There are a few caveats as far as AFib and stroke. So number one, the temporal relationship between AFib and stroke is still debated. Finding a brief episode of AFib, let's say a month or so after a stroke, does that necessarily mean that the AFib was the initial cause of the stroke? And another big thing to remember is the AFib burden. So the amount of time that the patient was actually spent in AFib, how much time does it really cause to increase your risk of an embolic stroke? And different time periods have been studied in different papers. And the other thing to think about is it's really difficult to determine what the exact AFib burden is without long-term continuous monitoring. And we know that an episode of AFib, at least 5 to 6 minutes, really doubles your risk of having an ischemic stroke. So would anticoagulation work for ESUS patients if this is presumed to be an embolic source and we know that AFib is so prevalent? Would anticoagulating these patients be helpful? So they did 2 large trials. The first one being Navigate ESUS, and that looked at 15 milligrams of rivaroxaban compared to 100 milligrams aspirin in ESUS patients. And the primary outcome was recurrent stroke of any type or systemic embolism. And the primary safety outcome was basically major bleeding. It was a large trial. It was international, randomized, double-blind study. And the median follow-up for this particular, for Navigate ESUS, was 11 months. And this study actually got terminated early. Number one being that there was no benefit, and the other thing is that there was an increased bleeding risk. So as you can see, on this side here is basically the Kaplan-Meier for the primary outcome. Again, any recurrent stroke or systemic embolism, and over here is bleeding risk. So there was no significant difference between the effect of anticoagulation and aspirin, and there was a significantly increased bleeding risk with rivaroxaban versus aspirin. And here's the data here. Again, as you can see, no difference in the primary outcome. The secondary outcomes, just pointing out, looking at recurrent ischemic stroke alone, there was actually no difference. And the safety outcomes, again, major bleeding, including intracranial bleeding and life-threatening bleeding, was worse in the rivaroxaban group or anticoagulation group. So the second study was RESPECT ESUS, and that looked at dabigatran versus aspirin, and the majority of patients in the anticoagulation group did get the 150 milligram dose. Patients got the lower dose based on their age or GFR. And again, the primary outcome was any recurrent stroke. The primary safety outcome was major bleeding. Again, it was a large international randomized trial, and the median follow-up for this paper was 19 months. The primary outcome in any recurrent stroke, there was no significant difference, and there was also the rate of major bleeding was similar between the dabigatran and aspirin groups. Again, here's the data to look at. The primary outcome, any recurrent stroke, and here are the secondary outcomes as well. Both of these papers could not calculate if there was significant difference between the secondary outcomes. However, looking at ischemic stroke here is a rate of 4% per year versus 4.7% per year, and here's the hazard ratio and confidence interval there. Again, major bleeding, there was no significant difference. However, in the non-major bleeding but still clinically relevant bleeding, there was more in the dabigatran group versus aspirin group. Now, looking at these two trials, there are some things to keep in mind. Number one, the median NIH in both of the trials was 1. So we're dealing with very minor, very small strokes here. The mean age in each trial was 64 and 67, respectively. In my opinion, they could have put more female subjects in there. In RESPECT, there was only about 36, 37% female, and then NAVIGATE, still less than 40% of the subjects were female. The majority of these patients were enrolled after their first ever ischemic stroke. So they didn't particularly include a lot of patients with, let's say, a recurrent stroke or multiple strokes. And each paper had their own selection criteria, but in the NAVIGATE paper, which was the rivaroxaban one, they actually didn't require intracranial imaging. And 22% of the subjects didn't even get like a CTA head or an MRI head. And if you remember the graphs, I'll go back actually. In the RESPECT ESUS, when they did like a post-hoc analysis, the dabigatran group, let me go back here. As you could see, after 1 year, there was a suggestion that the dabigatran group did benefit, but this was sort of later on in follow-up after 1 year's time. So, are these patients something that we would encounter in the real world? Do these really reflect patients that we see? So going back to the case, we just looked at his MRI, we looked at his CTA, which was normal. So his transthoracic echo was essentially normal. And, we wanted to look further, so we got a TEE. There was no thrombus, but, well, here he has an ASA and a large PFO with a big right to left shunt, with and without Valsalva. Let's see, hopefully it'll work. Oh, it's not a real mouse, it's a pretend mouse. I guess, can we play it? Here we go. So this is the right atrium, that's the left atrium, and then this is the aortic valve. So look at all these bubbles just crossing over. So we've got a big PFO with a big right to left shunt here. So after we found that, we did some additional workup. We looked for a DVT, so his venous duplexes were negative. His in-hospital telemetry was normal sinus. There was no significant arrhythmias. We did a hypercoag panel, an ANA, and a antiphospholipid panel, all of which were negative. So the question we had to ask ourselves is, is this person's stroke actually related to the PFO? Is the PFO pathological? Are we dealing with a paradoxical embolus here? And an embolic mechanism is obviously suspected based on what we see. He does have a lot of vascular risk factors. Remember, he's a diabetic, he has hypertension, he has hyperlipidemia. His ROPE score was 5. Remember the ROPE score being up to 10, 10 being the likelihood is very high that the PFO is related versus 0, which is the likelihood is low. So I decided to anticoagulate him. We put him on apixaban, and we have a good relationship with the cardiologist, so we were basically planning on doing prolonged heart monitoring. And if no AFib was found, then we would consider closing the PFO on this patient. So for those of you that don't know, this is AFib. So on the follow-up halter, there we go, we have AFib. So that, based on his, CHADS VAS score, anticoagulation is going to benefit this person in the long run. So he's tolerating anticoagulation well. He really doesn't have any residual deficits. So looking back, the PFO was probably incidental. It was probably a moot point given the fact that we found AFib and he's going to need anticoagulation in the long run anyway. So the thing that I wanted to stress here is that ESUS is not a single entity. It's a heterogeneous population. There are multiple potential mechanisms at play. And secondary stroke prevention, it needs to be individualized, on a case-by-case basis. More data is needed to figure out the patient selection, which patients are actually going to benefit for anticoagulation versus not. When someone has an embolic stroke of undetermined source, additional workup is needed, further workup is needed to figure out any other additional occult risk factors. In our center, in the absence of significant or definitive AFib, we consider implantable cardiac devices pretty much in the majority of ESUS patients if they have any potential risk for AFib. Short-term monitoring is usually less productive for finding a significant arrhythmia, and the implantable loops, implantable cardiac devices provide more consistent and more reliable data. So that was it, but my main focus here is that ESUS it needs to be individualized. It's a heterogeneous population, and speaking about AI and algorithms, I tried to sort of make an algorithm for ESUS, but I don't think that's possible. Everything has to be individualized here, and clinical judgment, has to be used, and you have to have a high suspicion, high index of suspicion for what the actual source is. And that's it, so thank you.